So first I'd like to thank the Academy for having me here. And as a little homage to my partner, Dr. Malanga, who's been passed, he usually had 120 slides for 10 minutes talk, and I would help him wean it down. So I just have 60 for 20 minutes. So hopefully this is not too fast. I'm a New Yorker, so I speak a little fast. The good news is that these slides should be for you, and there are a lot of references, so some things I'm going to blow over, so you can look back at them as a reference later and look up what you think is pertinent or you want to know about or more about. Two is that it's not just me making a statement, there's actually something behind what I made a statement of. And so we'll try to move forward. My disclosures, I'm a partner and founding member of Data Biologics, a company looking at real world evidence for these things we're going to talk about as well as others, with this disruptive and novel technologies out there that we can advance our patient care and outcomes. I have sort of a tough task to go over sort of everything at a 60,000 foot view, so hopefully you come away with actually some points, maybe not some specifics, but the gestalt of different things. Introduce the topic, give some definitions as I go through, the history of things that are probably going to be definitely different than what you thought you're going to hear when you walked in. The quote products that are being used, regulation, just touch on it a little bit, resources and training so you know there's stuff out there for you. You can look back and get those. And then just a little tiny comment on cost. So definitions, let's define at least what we're going to talk about. And that is the field of regenerative medicine and sort of what is that. Initially, some people said it's restorative and then maybe it's not. And are we really regenerating anything? Is it just a pain treatment? Well, I mean, every day we're regenerating the skin in our gut and our skin sloughing from our body. So we're regenerating ourselves from everything. So that's sort of what we're trying to do is get us back from the diseased tissue healthy versus what our bodies do every day with just replacing normal tissue with aging tissue. So it's a field of the science of repair, restoration, and regeneration of diseased or injured cells, tissue, or organs to restore homeostasis or balance. So often the regenerative medicine is really not discussed in different disciplines that we learn. And it probably should just be incorporated in that continuum along the care that we deliver, whether it's for tennis elbow, or radiculopathy, or something else. The other thing is, let's just step back a little bit. I know we're focused in on let's hear about regenerative medicine, but let's talk about the most important person in the room, the patient. Right? So we as physiatrists are biased in a good way, I think, and that is we're looking at impaired function and quality of life. And that's ultimately what we want to do is improve both of those factors. So looking at the whole patient and thinking about what is their mental, physical, spiritual aspects, what medicines are they on that may be detrimental to what we're trying to achieve, what are the supplements they may or may not need, right? Supplements are supposed to supplement things, not just 50 that they brought in a bag that they take. And then what is their goal, right? I talk to my patients and say, how you doing when they come in for follow-up? And I usually tell the story of two patients. One is, I think they're a failure, and I sort of in my back of my head. And the patient says, no, this is the greatest thing since sliced bread. I can walk up and down my split level, I can get on the floor and play with my grandkids, I love it. I'm like, okay, success. Yeah. On the other end, I have somebody who's, active, and they come in, I go, they're like 90, 95% better. And they go, this failed, this sucked, this is horrible. I go, really, what happened? Like, well, I can't heli ski out backcountry, I can't do CrossFit. I'm like, well, you weren't doing those before. He's like, but this was gonna give me that opportunity. I'm like, okay. So know your patients and their goals. We don't want to medicalize patients. That's what we do, right? We have a white coat, you need me, come in and see me. My goal is to get these people independent, empower them, and get them out of my office. I don't want to see them again. Unless they send me a card saying, I love how well you did. So we think about their general health. Maybe we need to precondition them with good exercise and modify their bad biomechanics, why they have this knee pain or back pain. And then maybe one of the most important things that, again, biased in this room, I hope, is good rehab protocol that we define, not just the black box of physical therapy. So we're going to start back in the 1500 or the 1350 BC, right? But we'll go a little faster. You look at Aristotle, looked at animals and the limb regeneration. It's like, wow, you lop this little lizard's arm off and it pops back, or the tail. That's cool. Can we do it in humans? Well, now I'm going to start with something called prolotherapy. So some people may have heard about it, and I think this is the grandfather term and treatment of all of what we're talking about in the future. It's stimulating your body to heal itself. We first reported in animals in 27. They thought it was a sclerosing agent, and they had a society they started, a medical group of people for treating hernias. Then you fast forward a little bit, in the 50s, you have a general surgeon who started looking at things, and they had disc syndrome, looked at management of hypermobile SI joint, started looking at sclerosing syndromes in the back. And then you started another group outside the hernia group that looked more at just sclerosing pain management. And you advanced till today. In 2009, they switched to the Prolotherapy Sclerosing Society that exists still today. And what's the mechanism of action? Well, dextrose, which is a typical thing in prolotherapy, is mobilizing the proliferation of growth factors to promote healing of soft tissues and potentially other structures. So then you have George Hackett, one of the fathers, and he was looking at injecting things in 35, and then wrote a book and coined the term prolotherapy or proliferant therapy in the 50s. And there's no data, right? But he looked at over 1,800 patients for 20 years to get over 80% improvement and no complications. No complications, right? Above all, do no harm. So people are like, oh, that's a bunch of bunk. Yeah, they don't really want to learn about what may help our patients. But so why isn't this present day use and paid for by everybody and everything? We could debate that, but at the same time, Mixter was talking about, you know, the disc and starting to do spine surgery, and all of a sudden we know how spine surgery has exploded. Maybe that's the reason, who knows? So as I said, classic prolotherapy is using sugar water, or P2G is phenol, glycerin, and glucose. And most of the things people talk about, that would be dextrose prolotherapy. So we want to look at this specifically for one thing, and that is people were treated with saline and with dextrose prolotherapy. And the important thing in this is they both did well. So saline is not a control. It's maybe a less effective therapeutic treatment, but it's not a control. So this study has impacted me quite a bit because of the technique. I've modified what they do, but this person in the UK looked at 21 people, did dextrose prolotherapy, and looked at the spine, with the red being where they inserted it through the skin and the black being where they actually injected it at the bone interface. And he looked at two groups, very long pain, 8 years, and long pain, but not so bad at 8 months. Being quite disabled between 12 and 44 on the ODI, Oswestry Disability Index. Higher it is, the worse you are doing. 18 patients had over 86% improvement, defined how? Over 70% improvement in pain, and over 80% improvement in the disability or patient-reported outcome scales. And that's in a year. 2 of them were unchanged, 1 has a little bit worse, and as we look at medicine, everything won't cure everybody. And if they do, then you gotta question why that's happening. So you can look at low back pain that radiates down the leg, potentially radiculopathy, do caudal epidural injections, about 5 a year. And listen, feel like it's too expensive, it's not covered by insurance, it's gotta be, I don't have fluoro. I learned in a third world country with a 25 gauge needle how to do a caudal epidural injection with no guidance. You can do it. And you can make it really inexpensive for patients to put in their office. So if you're in an indigent area, you're in inner city, you can do this. There's a will, there's a way. And in 1 year, it improved disability and pain. Coding. People love to get creatively coding for all these things we're gonna talk about. Don't do it. Or take the same amount of money you got paid and put that into the bank account for the lawyer. So there's a Higgs-Pix code not covered by Medicare. You can't put dextrose in something as a primary treatment and code it as an injection of a joint, a tendon, a ligament, because that's by definition prolotherapy. And that should be knocked out, and it's fraud. Internally, we use a Medicare guidance of that figure you see up there of how we code sort of our stuff internally. So depending on where we're treating and how we charge. Ozone. Well, Pericles said that all things are poison and nothing is without poison. The dosage alone makes it such a thing that is not a poison. So devil's in the details, as we heard earlier. I got stem cells in my back. What the heck does that even mean? And dose, devil's in the dose, right? That's also important. So ozone first discovered in 1785. As you can see, lots of things that'll be there to look back if you don't believe me or agree. And around 2006, Spanish Society developed a group, and it's the Spanish society that made a really dense article that sort of covered the soup to nuts on ozone. Made a Madrid documentation. And the important thing is the bottom, right? Ozone's practiced in more than 50 countries, and there's more than 40 medical societies. So nobody may have heard of this, except for maybe Dr. Rogers, in this audience. But it's being used a lot around the world because it's cheap, it can't be patented, and it's effective, and it's safe. We wouldn't want that in the United States, would we? Okay. All right, but we said, right, FDA says, no, ozone by definition is a toxic substance with no medicinal use. However, sorry about the error, it's not contraindicated, it's conflicting, right? So contradictory by the Vasogen studies that FDA certified and approved, phase 1, 2, 3, that they agreed it was safe. The effectiveness wasn't looked at because it wasn't a study for the spine, but we do know that ozone is safe, and the FDA knows that too. Again, it's used in general dentistry where they actually have continuing medical education, articles on infection and other things. And with the new administration, depending on who's there, I have some inside information, we may hear more about ozone. So if you take proliferative therapy, dextrose prolotherapy, and you switch it up a little bit, you get prolozone, proliferative therapy with ozone. Dr. Schellenberger registered this term. I was lucky enough to be on the founding group in 2010 of the American Academy of Ozonotherapy, and essentially it's using a different stimulus of gas, ozone gas, instead of dextrose. Gas flows completely differently in the tissue under ultrasound than everything else you think about, from magic pixie dust that's liquid. Ozone for the spine, right? We all know, or hopefully we know, that you can take two groups of people with disc herniation and radiculopathy, follow them out if you can manage their pain, and at 1 year later, not statistically relevant, but the non-surgical group is a little bit better, so you can get there. Well, how about we just take these people who are having a tough time and we do ozone? So half have ozone, half have surgery. 71% of people that had the ozone avoided having surgery. That's pretty good odds to me to try. There's other studies, so you look at ozone in the back, 70 to 80% improvement. Ozone in the neck, 70 to 80% improvement. Less studies, but they're out there. Again, some summaries if you want to go back and look, there's some there. So another definition. Regenerative medicine, it's a new branch of medicine that will develop, that attempts to change the course of chronic disease, and in many instances will regenerate tired or failing organ systems. So that's what we're trying to do with what we're talking about. We get so enamored by technology and this magic pixie dust called stem cell, and it's going to cure everything. It's going to be the wonderful thing, but we have to remember, Bruce Lipton wrote a book called Biology of Belief. I always tell my patients, like, what's the most important thing in your healthcare? And they're like, I go, your mindset. Because if they go, this stuff might work, guess what? More difficult for me to help them. Or as you hear about, I know how much money it costs, so it must work. So I'm already in on this. So that's beneficial. I mean, use everything we can to make someone better. Address their suffering, address their quality of life, get them better. Again, I treat patients, not pictures. I have to register that. But we know you can image a lot of people with no back pain, no back injuries. 66% there's a disc abnormality. We can look at people that are younger, image their necks, lots of disc abnormalities, right? But we follow them for 10 years, and guess what happens? Only 30, they advance, much more incidence of abnormalities, but only 34% actually develop symptoms. So we have to treat patients. Hopefully anybody doing spine in this room, right, you don't look at an MRI or an X-ray and go, well, their facets look fine, so it must be something else. We do diagnostic medial branch blocks, and then we make a diagnosis of facet syndrome. Nothing to do with imaging. So to me, I always say to my patients, I go, imaging is pretty much useless. I go, if you don't have a tumor, fracture, something else, whatever, I don't care. You're just gonna feel bad, your bad looks horrible. I mean, so what? You're hiking, running marathons, doing whatever, don't worry about it. Take time to listen to the patient, evaluate them functionally, figure out their movement patterns, see if they just need rehab, good rehab, not just rehab. Well, think about the fascia, right? The surgeons will cut through the fascia and then screw up the entire chain, and then we wonder why they're even more problematic after. So we have to think about the victim and not the culprit. We have to figure out the source of the problem, not the symptoms. We have to figure out this sort of search for the pain generator, because we don't really care about a disc herniation a lot of times, right? That happened why? You had bad posture, bad loading, ultimate failure years later, you herniate a disc. When the disc compresses on a vital nerve root in a structural area that has no give like that, now we care because you have an acute radiculopathy. But the problem was the posture 20 years ago. Is there resets like this, right? I got another definition from the National Science Foundation, so you can see the theme. There's a lot of definitions, and they're somewhat close, but we need to make sure that we understand what we're talking about together. Another reason I got into this field was I got annoyed with the connotation of inflammation in med school and residency. Inflammation's bad. I'm like, well, what I learned, if you cut yourself, God gave us this inflammation as a gift to heal. So why is it always bad? And then you hear about, in the very beginning when we talked about regenerative medicine, people brought up this wound curve. I was like, that doesn't make sense. That's BS, right? Why? You have an open wound. I'm like, we're not doing that. And so you look at Dr. Kaplan's comments and whatnot, and that wound curve probably doesn't apply at all. So you take a tennis elbow and there's no opening, it's under there. Has anybody looked at the microducial catheters to see the phases and when you put PRP, what happens? Not that I know of. So we're probably looking at modulation. And if we remember back to med school, the immune system and the pain system are intimately connected. And we forget about that. If we look at someone who gets better, they might get better in 3 to 4 weeks and plateau around 12 to 14 weeks. Or Dr. Centeno just looked at this thing at 6 years and people were still improving with their spine injections at 2 years. And so, if it was really healing, it may take 12 to 14 months for people to get better, and yet they're getting improvement clinically at 3-4 weeks. It's probably an immunomodulatory phase that's happening. So PRP, the next lecture is going to go in much more detail, but it was sort of started in '54, used in cardiac and dentistry quite a bit. First sort of regenerative side was around 1998, and then really took a lot of traction to the mainstream when Heinz Ward in 2009 got it before the Super Bowl, and all of a sudden it's like everywhere. It's like, wow, what's this PRP stuff? And then people ask you like, hey, that thing that Heinz Ward got, can I have some of that squirted in my knee? The problem is these studies you may have read, like, they don't work at all. Well, they work great. Who knows? Well, I'm going to do this study, and I'm going to do antibiotic for pneumonia, and it works or not. Well, I didn't tell you the dose, the frequency, or the duration. Well, of course, who's going to publish that? But it's exactly what's been happening in PRP, is that we don't know what's actually being administered to the spine or otherwise. Now, we have some inkling on some of it where you can split it out. We know a higher dose of PRP might be better, but we have to be better. And part of it is we developed a classification system. Magalone developed a great classification system. So it's incumbent upon the editors not to publish something unless we know what's in there, and not just like it's cool, let's publish. We have enough of that crap. And then stem cell, well, that term thrown around, magic pixie dust, 1908, Dr. Kaplan really looked at the whole lineage in the 1980s and coined the term mesenchymal stem cells. But he said he missed the boat a little bit, which I'll bring up in a second. The problem again is just like PRP, what's the nomenclature, what's the definition? Well, on one side you have the International Society for Stem Cell Research in 2002, but they're mainly basic scientists. They have different goals and they have different reasons for saying what they say. And most of their stuff is an in vitro model. And we're looking at in vivo outcomes. So we need to have a consensus on terminology. So Kaplan in 2010 decided to change things and said, you know what, I screwed up a little bit. Number one is I didn't get the precursor to stem cells, the periocyte, that lives on all the vasculature in our body. So when you cut your little finger, you release that off and it modulates the way things happen. And then they shouldn't really be called mesenchymal stem cells, but let's keep MSCs and call them medicinal signaling cells. Because that's really what these stem cells are doing, is they're modulating your body's ability to heal. They don't really become that target tissue. So he's like, listen, I can put these stem cells in a petri dish and I can make them dance and they can do the jig. He goes, but if I give them the right stuff, I can push them to cartilage, I can push them to skin, I can push them to nerve, I can push them to fat. That's not what happens in your body. So the whole mission, until he passed away recently, from 2010, was to get everybody to understand that this is the way they work, not the way everybody talks about. So 3/4 of my consults are done doing misinformation from what they've heard from TV or even my peers and other physicians. So like I said, the periocytes and then how they actually function in the body versus in the petri dish. Orthobiologics, there's a whole bunch of names, right? They come from blood, bone marrow, fat, periumbilical, perinatal, and some are more than minimally manipulated, so they might fall in a different category. So there's a lot of stuff out there. The field of regenerative medicine has grown enormously, in part due to the failures of standard traditional care and surgery. Either they don't get the outcome they want, or they're laid up a lot longer than they want. Unfortunately, a lot of our peers are just people out there who have said things in sort of hyperbolous fashion that everybody gets better, and so people are going after it. Have to give kudos to Dr. Centeno. He started some of this early on, and he put a lot of effort into money, time, and work into collecting data. And that was really the first thing, and he collected data. So, we pound that, data. That's what I think is one of his greatest legacies, although he's done a ton of stuff. And so we ended up doing the same kind of thing, is we started a company called Data Biologics. It's open to anybody that wants to look at novel treatments that don't have to just be regenerative medicine focused. To get real world evidence. Why? Because those kinds of things that you're doing and seeing in your clinic you think are working are disruptive technologies. They change the status quo. And I'm a conspiracy theorist. And I get everybody to agree my conspiracy theories. The conspiracy to the status quo. Right, if I could do something and flick my fingers right now and eliminate breast cancer, nobody would want that. You'd put half the country out of business, right? So things have to evolve slowly. But we don't want this from research for 17 years until it gets adopted in clinical practice. We want to get it adopted at a much faster pace with good evidence at 4 or 5 years. So despite people adopting a lot of these treatments, unfortunately with these great claims, they don't put effort into collecting their data to tell me with the data that they actually made a patient better. And define those kinds of things like, yeah, I went to X and I got stem cells. And you get the notes from it, it says, this is truly stem cells, not what I just said. This is how many were alive, this is the number, this is exactly where I put them. I mean, I get stuff from dermatologists and cardiologists who are treating spine pain, and I look at their notes and I'm like, holy crap. So to me, it's lazy, it's unethical, it's just not acceptable that people are doing novel things and they're not collecting their data. So there's a lot of sort of people like there's no data, and there's a lot of data. The problem is we don't have that data, which you're sort of here today for, is what can I do to my patient on Monday morning? And that translational data, that phase 3 data, is what do we know? Well, Dr. Chu is going to tell a little bit about the future coming, so we will have some of this. The good news is we're getting a groundswell of data. So for decades, 3 decades, we've had a lot of research, but nothing yet to really tell us this is exactly what I need to do for this patient yet. Part of this is research problems. Unlike, say, a product that you have got a company behind it, or it's got an industry behind it that figures out how they can monetize it, this is everywhere. It's various fields. Nobody's really got a common voice. There's different terminology, nomenclature, different focuses for research, different financial supports and interests, different ways of collecting data you can't compare across. Like, look at all the PRP studies. They all have different outcomes data. So how do you even compare two people who looked and did the same thing for knee arthritis? And then we make bad assumptions about these things. And then priorities. My priority is to make a lot of money. My priority is to get this guy's knee better. My priority is to help the spine. So I'm not a lawyer, but this is the most important part of the lecture. A lot of stuff for your slides, but I'm going to try to break it down into 2 general categories. On one side, you have 351 and 361, division in the code that talks in details about what that means from the government. So on one side, you can think about it as this thing has whatever characteristics that is a drug. If it's a drug, it's under FDA purview and needs to go that route. If it's not, it's the practice of medicine, and therefore it's unregulated, right? Nope. We all have a state board of medical examiners that regulate it, so you still have to do the right thing. And then remember, there's a lot of regulatory terms that people talk about. You should know what IRBs are and INDs, and it's like, oh, you can use our product because we have an IRB. No, that doesn't necessarily mean it. So remember, you're on the hook. You need to know what's going on. Don't trust the drug rep, don't trust some other guy, because when the FDA comes knocking on your door or some other governmental agency, you're on the hook, they're gone, they're out of business. Words matter, so be very careful about what you put, like stem cells on your website, because that's FTC purview and you might get into some big regulatory problems with that. Be careful in your notes. Make sure you're not documenting putting stem cells in when you're putting something that's been irradiated and everything's been killed and it's just growth factors. So I want to put out also 2 major cases, we'll call it. One, the regenerative sciences, they were culture expanding out of bone marrow. And that essentially put out as that's a drug. That doesn't mean you can't get it. It just means that now has to go through the FDA pathway, and that has to be then regulated by the FDA as a drug. You can do that, and the Cures Act has allowed a potentially expedited way to do that more efficiently versus the antiquated way to, say, put an antibiotic chemical through that pathway. And Dr. Chu will probably talk a little bit about those kind of drug pathways. And then, fat, is it a drug or not? Well, probably not fat as a tissue as a drug, but if you do something like SVF, stromal vascular fraction, that is a drug now with the last appellate decision, just recently came out, that's a drug. So as I said earlier, State Board of Medical Examiners, so you need to read this document, the Federation of State Board of Medical Examiners, because that's sort of overall of all those different states, and that has a lot of good information on regenerative medicine and how you should do certain things. I mentioned the 21st Century Cures Act. The important thing is that it allows an expedited potential way for biologic cellular treatments to get through the FDA, even though it's still a little antiquated because they're still looking at sort of getting a chemical and going through the chemical pathway and then making a Botox or an antibiotic or whatever. Oops, sorry, go back. Right to Try is a fantastic thing that was signed in 2018, and that essentially allows someone who's got end-stage disease, could be whatever, to allow to have some novel treatment. It doesn't just apply to our field, but we particularly can apply it here for someone who may have end-stage knee arthritis. They've had everything you can think of except surgery. They're too old or too sick to go through surgery because it might kill them. And then they're a potential patient for Right to Try using stem cells or something else, true stem cells. Guidelines here, something for you to look at if you want some guidelines. From the AAOS, their guidelines on PRP as well as on stem cell therapy. Societies, there's a bunch of societies out there. The Academy is doing some work here. They actually put out a recent publication that was fantastic about what you should sort of learn in a stem cell fellowship, or regenerative medicine fellowships. They did a lot of work with collaborative other organizations. We're one of the few people, we actually have a regenerative medicine fellowship, so if anybody's interested. Data Biologics collects real world data, so that's always a good place to go to do it hopefully simply for you. There are books out there, a couple written by my partner who passed away, Dr. Malanga. The ACIP has some good, big books for references. Cost. So a quick little comment. This is disruptive technology we're talking about. This is going to have a lot of resistance. So we need to prove this and prove it well. We need to have overwhelming data. First, safety, and second, efficacy. So we need more data, right, for everything, but this is really important for this particular field to go. So hopefully I've given you some ideas to think about, expand, and not just shut down and take a nap. This will hopefully get you thinking about the next thing that you can do and try novel for your patients. And then the conclusions, hopefully I've addressed this, says that regenerative medicine, that we can term as orthobiologics for this particular lecture and field, is it consists of lots of, quote, products or treatments. Some of these treatments have a long track record, we're a lot of history, but we haven't really translated some of that yet into exactly what problem and what treatment to do. The research is growing with real world evidence, hopefully leading that charge, and then it can help us define what we can do RCTs on. And then this is safe, or at least safer than the traditional treatments that we give. And there's a significant and dramatically changing regulatory landscape that you guys need to keep apprised of, because that's where you're gonna get most hurt. And there are a lot of resources that are also really starting to explode over the last couple of years. So hopefully I didn't go too long, but we can take questions at the end, and it should be hopefully a lively discussion.